distinguished faculties from home and abroad, and the learned audience. Assalamu alaikum. Now I am going through my paper. European Society of Gynaecological Oncology, Quality Indicators for the Surgical Treatment of Endometrial Carcinoma. This is a society statement published recently in November 2021 at International Journal of Gynecological Cancer, and the principal author was Nicole Conse. Background. Optimizing and ensuring the quality of surgical care is essential to improve the management and outcome of patients with endometrial carcinoma. It's enable healthcare professionals to compare their clinical management with ideal standards of care. The European Society of Gynaecological Oncology initiated a project to develop a list of quality indicators for surgical treatment of endometrial carcinoma. Methods. The ESGO Council nominated 17 gynec-oncologists as international development group members. Then the potential quality indicators are identified through systematic literature search. At first meeting, international development group members discussed each potential quality indicator. There was an international review by independent external panel of physicians. And at the second meeting, discussion and integration of external reviewers' comments, final decision taken on definition of quality indicators, specifications, and targets. Results. There are 29 quality indicators with specified targets. Quality indicator 1, at least 50 of newly diagnosed cases of endometrial carcinoma should be treated per center per year. Quality indicator 2, at least 50 endometrial carcinoma primary surgeries performed per center per year. Optimal target is 80 or more. Indicator 3, 95% or more surgery should be performed by a gynecologic oncologist or a trained surgeon specifically dedicated to gynecological cancer management. Indicator 4, treatment and or follow-up plan discussed at a multidisciplinary team meeting, 90% for primary treatment, and for relapse cases, 99%. Quality indicator 5, center participation in ongoing prospective studies in endometrial carcinoma or at least in gynecological oncology. Quality indicator 6, a preoperative workup according to the ESGO-ESTRO ESP guidelines should be performed in 90% of the cases. Quality indicator 7, less than 5% of the cases of presumed FIGO stage 1 to 2 may be upstage to 4B disease. Indicator 8, 99% of cases of early stage endometrial carcinoma with result in a non-ruptured uterine specimen after hysterectomy. Quality indicator 9, at least 60% of the patients with early stage endometrial carcinoma should have undergone successful minimally invasive surgery. And indicator 10, more than 60% of the patients with BMI more than 35 kg per meter square should have undergone successful minimally invasive surgery. Quality indicator 11, conversion from minimally invasive surgery to open surgery should be less than 10%. Indicator 12, there should be intraoperative injuries in less than 2% patients. Quality indicator 13, infracranial omentectomy in patients with endometrial carcinoma and presumed early stage serous undifferentiated carcinoma or carcinosarcoma in 90% or more cases. Indicator 4, lymph node staging performed in patients with presumed early stage high intermediate or high risk endometrial carcinoma in more than 85% cases. Quality indicator 5, sentinel lymph node mapping should be done in patients undergoing lymph node staging in 90% cases. Indicator 16, during sentinel lymph node mapping procedure, endometrial carcinoma performed or supervised per surgeon per year should be 20 or more. Indicator 17, during lymph node mapping, injection indocyanine green cervical injection should be given in 95% or more cases. Quality indicator 18, site-specific systematic pelvic lymphadenectomy in cases failed sentinel lymph node detection should be performed in more than 90% cases. Quality indicator 19. In more than 90% cases, patients who underwent ultrastaging of the sentinel lymph node should be done. Quality indicator 20, bilateral mapping rate should be 75% or more. Quality indicator 21, complete macroscopic resection for curative intents in more than 75% of the patients with primary advanced endometrial carcinoma. Indicator 22, complete macroscopic resection must be achieved for patients who underwent salvage surgery for isolated locoregional recurrent disease in more than 85% cases. Quality indicator 23. There should be complete molecular classification of the tumor according to the ASTRO-ESP guideline, at least in 50% of the cases. Quality indicator 24, compliance with the ASTRO-ESP adjuvant treatment guidelines based on prognostic risk group stratification in 90% or more cases. Quality indicator 25, surgical report should be recorded according to the ASTRO-ESP guidelines in 99% or more cases. Quality indicator 26, same as for the pathology report in 99% or more cases. Quality indicator 27, there should be at least 2 structured morbidity and mortality conference per year for quality assurance of surgical care. Optimal target is 4. Indicator 28, reoperation within 30 days for complication after primary minimally invasive surgery should be less than 2%. Quality indicator 29, structured prospective reporting of the recurrence or death at least once a year. Now accreditation. This is an award to the institute who are giving standard of care for the patients with endometrial carcinoma surgery, and it's based on the completion of this quality indicator. A scoring system has been developed, and the accredited institute are entitled to use the subtitle ESGO accredited center in the endometrial carcinoma surgery and categorized as either standard accreditation or center of excellence. Strength of the processes. It includes involvement of the international development group, expert consensus to support the quality indicators, external review process, structured format to present the quality indicators, and management of potential conflicts of interest. And the limitation is inherent bias related to the consensus of experts. In conclusion, the system will have to be refined in the future with the feedback provided by the scoring of the candidate centers and by prospective research on the multivariate correlation between survival outcome, characteristics of the patient, and indicators. Thank you for patient hearing.
Respected Chairperson, distinguished faculties from home and abroad, and learned audience, Assalamu alaikum and very good evening. Today I will talk, next slide. Today I will talk on a review article, The Emerging Role of Molecular Pathology in Directing the Systemic Treatment of Endometrial Cancer by Amy Jamieson et al. It was published in the Therapeutic Advances in Medical Oncology Journal in their 13th volume in 2021. Next. Pathological review of the patient who participated in the PROTECT-3 trial have shown significant disagreement in the stage and other risk group defining criteria which are used traditionally in the plan of management for endometrial cancer, resulting over and under treatment of many women. In 2013, the Cancer Genome Atlas has discovered 4 molecular subtypes based on genome architecture. Following this discovery, the subsequent studies use surrogate marker to develop and validate a clinically relevant endometrial cancer classification tool. They use combination of sequencing to identify mutation in DNA polymerase epsilon and immunohistochemistry for mismatch repair protein and p53 protein, and thus yielding 4 molecular subtypes: polymutant, mismatch repair deficient, p53 abnormal, and NSMP, that is no specific molecular profile type. This molecular classification of endometrial cancer has shown highly reproducible, high concordance between the preoperative biopsy and final hysterectomy specimen with high interlaboratory concordance. Moreover, it creates a framework to approach treatment decision in both conventional and targeted therapy. Next. Mismatch repair deficient endometrial cancer. This group has intermediate prognosis. They have loss of DNA mismatch repair protein. They are identified by microsatellite instability testing and testing for the loss of expression of MLH1, MSH2, MSH6, and PMS2. These are highly immunogenic tumor and associated with improved patient survival. Then adjuvant therapy. Radiation therapy is the conventional adjuvant therapy for this group of endometrial cancer. And retrospective molecular analysis of P50 of PROTECT3 trial have shown no benefit of adding chemotherapy over radiation therapy for this type of endometrial cancer. Another option is immune checkpoint blocker. Pembrolizumab is the first agent with favorable objective response rate of more than 50%. Other agents may be used as single agent like nivolumab, avelumab, durvalumab, or immune checkpoint inhibitor may be used along with other agents like anti-angiogenic factor lenvatinib. P53 abnormal endometrial cancer, this is the most aggressive and lethal subtype, account for only 15%, but responsible for more than 50% of the endometrial cancer mortality. They have ubiquitous P53 mutation and identified by mutant pattern P53 IC staining. Next. Retrospective molecular analysis of PROTECT3 trial for high-risk patients have shown significantly improve outcome when chemotherapy is added over pelvic radiation therapy. And and PARP inhibitor, single olaparib is not effective, but rather olaparib in combination with cediranib is have shown modest efficacy. Anti-human epidermal growth factor 2, trastuzumab, has a disappointing result in previous trial. Bevacizumab, in addition with chemotherapy, no significant improvement in progression-free survival was observed in previous trial. And UE1 inhibitor adavosertib in recurrent uterine serous carcinoma is under trial. NSMP, endometrial cancer, this is the most common molecular subtype having intermediate prognosis. They have high level of ERPR expression. And biomarker here is beta-catenin mutation status and L1 cell addition molecule overexpression. Next. Hormonal therapy is being traditionally used for this type of cancer in mostly in the recurrent and metastatic setting with 20% response rate. Hormonal therapy may be used along with targeted therapy like letrozole plus everolimus or letrozole, everolimus, and metformin combination. Next. Least common molecular subtype is polymutant endometrial cancer. They have improved patient survival outcome. Meta-analysis of all polymutant endometrial cancer have shown excellent survival outcome in early stage. And 2020 ESGO-ESTRO ESP guideline classifies stage 1 and 2 polymutant endometrial cancer as low risk, and omission of adjuvant therapy should be considered for this type of cancer. Now, 2 clinical trials are ongoing to assess the safety of de-escalation of adjuvant therapy, PROTECT4A and TAPR. This is the planned TransPROTECT refining adjuvant therapy in endometrial cancer based on molecular profile program of clinical trials. Here, molecular classification of all surgically resected endometrial cancer will be done. Then, RATE P53 abnormal trial is for P53 abnormal endometrial cancer. Here, patient will be assessed between chemoradiotherapy with or without DNA damage response targeting agent. Green MMRD trial is for MMRD endometrial cancer. Here, patient will be randomized between radiation therapy versus radiation therapy with immune checkpoint inhibitor. Orange NSMP trial is for NSMP endometrial cancer. Here, patient will be randomized between chemoradiotherapy versus radiation therapy with hormonal therapy. And blue POL trial for polymutant endometrial cancer. Here, patient will be randomized between radiation therapy versus no adjuvant treatment. Leon Castillo et al. Have found that endometrial cancer may have more than one molecular feature. That is, tumor with pathogenic mutation in poly may have MMRD or mutation, androgen mutation in the P53. But these are the secondary mutations that do not affect the clinical outcome. This highlights the importance of interpreting P53 and MMR-IC in the context of pol mutation status. Next. Molecular classification has offer objective and reproducible classification system, and clinical terms must be a priority, and it should be considered in all endometrial cancer and be incorporated into management decision. And lastly, thank you all for patient hearing. And I want to thank Oncology Club to giving me the opportunity to present this journal in such a big platform.
Okay, so I'm just going to summarize the 2 talks presented very nicely by the previous 2 speakers. So first one, I will begin with molecular classification. As all of you know that histological type, grade, stage, and various risk factors are very subjective. And there is a lot of inter and intra-observer difference, up to 30%, as shown by the POTEC 3 trial. And this results in under-treatment or over-treatment. And because of this, there is a significant difference in adjuvant treatment policies with radiation therapy, chemotherapy, and targeted therapy. So a lot of differences there as far as adjuvant treatment is concerned. Now, as against histological classification, molecular classification is very objective, and there is agreement between preoperative specimen and the postoperative specimen. Agreement between the pathologists. And most importantly, it gives you framework, objective framework to define the adjuvant treatment. Also, it is helpful in diagnosing hereditary cancers like Lynch syndrome. Now, let us take the important molecular marker, MMR deficiency. MMR basically it is represented by 4 proteins. Okay, and if there is a loss of nuclear expression of MLH1 and PMS2, then you have to do further testing called methylation testing. If MLH1 methylation is present, it indicates presence of sporadic cancer. In Lynch syndrome, there is no methylation. So in Lynch syndrome, there is no methylation of MLH1 syndrome. And in sporadic cancer, there is a methylation of MLH1 protein. Lynch syndrome also has BRAF mutation. This is how you can differentiate between Lynch syndrome and sporadic cancer. Now, MMRD tumors have macrosatellite instability. Because of macrosatellite instability, they are having hypermutations. And hypermutations cause neoantigens. And because of presence of neoantigens, they are highly immunogenic. Therefore, immunotherapy is effective. So patients who have MMR deficient tumor, probably they are very suitable for immunotherapy. Pembrolizumab has been approved for advanced and metastatic endometrial cancer. So also a combination of pembrolizumab and multi-kinase inhibitor, which is angiogenesis inhibitor called lenvatinib, has also been approved. So these two combinations have been approved for advanced and metastatic endometrial cancer who are MMR deficient. The advantage of adding lenvatinib is that it may help in overcoming resistance to pembrolizumab by inhibiting angiogenesis. Lenvatinib inhibits angiogenesis, and because of angiogenesis inhibition, there is a production of new antigen, and therefore they become more responsive to immunotherapy. Now, POTEC trial has shown that MMR deficient endometrial cancer, which belong to high-risk category, radiotherapy alone is enough. There is no need to add chemotherapy. Radiotherapy is as effective as combination of radiotherapy and chemotherapy. In MMR, if MMR deficient high-risk endometrial cancer, radiotherapy is enough. No need to add chemotherapy. Now you take P53 mutation. It represents aggressive endometrial cancer. And 5% of grade 1 tumors have endometrioid cancers have P53 mutation. But if you take serous cancers, almost all, 93% have P53 mutation. Okay, and POTEC trial has shown that whenever you have P53 mutation, they respond better with combination of radiotherapy and chemotherapy. So whenever you have a P53 mutation, chemotherapy is important. Whenever you have MMR deficiency, radiotherapy is important. Okay, and one more trial, GOG 258 trial showed that chemotherapy is equivalent to chemotherapy and radiotherapy in high-risk endometrial cancer. Now, P53 endometrial cancers are very aggressive cancer. They have worse prognosis. Chemotherapy alone may not be enough. But fortunately, P53 abnormal endometrial cancers also may have what is called as homologous recombination deficiency in up to 50%. So they can be treated with PARP inhibitor after chemotherapy. 25% of endometrial cancer with P53 abnormality, they have HER2 overexpression and they can be treated with trastuzumab along with chemotherapy. And some patients have overexpression of vascular endothelial growth factor and they may benefit from bevacizumab. So for P53 abnormal cancer, along with chemotherapy, we have option of PARP inhibitors, trastuzumab, and bevacizumab, which might improve the prognosis. Now, POL mutation, all of you know now that they are good cancer. Therefore, adjuvant therapy may be avoided even in high-risk factors. Grade 3 LVSI present, deep invasion is present. We can avoid adjuvant therapy altogether. Now coming to the quality indicators. The first talk, quality indicators of surgical treatment for endometrial cancer. Quality indicators are very important because in the last 1 decade, minimally invasive surgery, sentinel node biopsy, and molecular classification, they have redefined the management of endometrial cancer. Therefore, it is very important to maintain optimal management of endometrial cancer. And therefore, ESGO has defined 29 indicators for future ESGO accreditation, as already spoken by the previous speaker. I'll just summarize. In brief, a center should have minimum 50 endometrial cancers per year, ideally. Okay. And there should be a multidisciplinary team consisting of radiologist, radiation oncologist, pathologist, and person experienced in chemotherapy. This is very important. Now, most important thing is that whenever you are doing minimally invasive surgery, intraoperative rupture, intraoperative morcellation is not done, including in a bag. Should not do rupture of the uterus in a bag. Mini laparotomy is done to remove the large tumors. Conversion to open should be less than 10%. So you should avoid morcellation of the uterus whenever uterus is large. Better do a mini laparotomy. Now coming to the role of lymph node staging in stage 1 and stage 2. Now very important here to understand is that lymph node staging is defined as sentinel node procedure and or systemic pelvic node dissection. Okay. There is no mention of aortic node dissection. The more important thing is pelvic node dissection is more important. Aortic node dissection is not very important because the incidence of aortic node metastasis overall is very, very low whenever the imaging is normal. So according to ESGO guidelines, aortic lymph node dissection may be omitted when imaging is negative for suspicious aortic nodes. This is an important point to be remembered. Now, practicality of sentinel node procedure. Now, pathological ultra-staging of sentinel node biopsy is recommended. And you just should not rely only on frozen section. But most centers across the globe, they rely on frozen section and routine H&E staining. Very few centers carry out ultra staging. So whenever you are doing sentinel node biopsy, ultra staging is ideally preferred and should use ICG dye for sentinel node identification. And this needs expensive near infrared spectrum camera, which is very, very difficult to get it in underdeveloped and developing countries like India and Bangladesh. Now, surgery for stage 3 and stage 4 and also for recurrent disease should be performed only if complete resection is possible. Only if complete resection is possible, you should do surgery for stage 3 and stage 4. Now, molecular classification, minimum, I think target now at present should be 50%. For all of us, minimum 50% of our patients should have molecular classification. Optimally, it should be more than 90%. Molecular classification is still developing and very, very difficult to do it in developing countries. But we should have an aim of having target of 50%. Molecular classification helps in more accurate adjuvant therapy planning. To summarize, MMRD deficient high-risk endometrial cancer, radiotherapy alone is enough. P53 abnormal endometrial cancer, chemotherapy with or without trastuzumab, bevacizumab, and PARP inhibitor may be used. Thank you. Thank you so much. And for pathology reporting, you should use standardized pathology reporting format. Thank you.